Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to another cardiophysiology video in my cardiology playlist. Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to another cardiophysiology course. Your heart is like a factory. There is an input going into the heart and there is output leaving the heart. The input is via veins, whereas the output is through arteries. Any factory that has an output can measure that output, roughly speaking, by multiplying the number of employees times the productivity per employee. Similarly, you can calculate the cardiac output by multiplying how fast the heart is pumping, i.e. beats per minute, times the volume ejected per beat. I was not planning on making this video, however, a wonderful person named Jordan supported me generously and said, "Hey Medicosis, would you please create a cardiophysiology video?" My dear Jordan, of course I can, and your support means the world to me. So if you're watching this video right now, please take a moment and say thank you to Jordan in the comment section. Let's put a smile on his face today. And if anyone wants me to create a specific video on a specific topic, you can do so on my website. In today's lecture, we'll talk about the cardiac output, the cardiac index, heart rate, and stroke volume. We'll talk about the end-diastolic volume, end-systolic volume, ejection fraction, Starling Law versus Starling forces. Talk about compliance, which is the opposite of elasticity. We'll talk about the cardiac cycle and the dreaded, most hated pressure-volume loop. For some reason, students hate this, but it's actually a piece of cake if you understand it properly. This video builds upon previous videos in my biology playlist and in my cardiology playlist, such as the cardiovascular system video and my video on the cardiac cycle and blood pressure. Here's your wonderful heart. How many hearts do you have anatomically? 1. Physiologically? 2. There is the right heart and there is the left heart. Let's start here. Left ventricle pumps blood to the aorta. This is oxygenated blood. The aorta distributes this oxygenated blood to every organ in your body. Each cell takes in oxygen and nutrients from the arterial side and dishes out carbon dioxide and waste into the venous side. The venous side will go here, inferior vena cava and superior vena cava, right atrium, right ventricle, passing through the tricuspid valve. By the way, every valve in your heart has 3 cusps except this one. This one between the left atrium and the left ventricle has only 2 cusps. It's the mitral valve. Why do they call it mitral? Because it's similar to la mitre, which is a religious hat for some Catholic clergymen. Back to the deoxygenated blood in the right ventricle. It will be pumped through the pulmonic valve into the pulmonary artery, and then it will take me to the lungs. The lungs will get rid of that carbon dioxide through exhalation and then inhale some oxygen. All of that oxygenated blood will go to the left atrium via pulmonary veins. Then oxygenated blood enters left atrium, and then through the mitral valve we go to the left ventricle, and then you repeat the story again. What's the next valve here? Aortic valve. The basic idea is that your heart is a factory. There is input to that factory, there is output from that factory, and then you distribute the widgets. The input to the heart comes through veins. If you are the right heart, it comes through the superior and inferior vena cava. If you are the left heart, it came through the pulmonary veins. So input is venous. Let's talk about output. If you are the right ventricle, your output will go through the pulmonary veins. If you are the left ventricle, your output will go through the aorta. So the output is arterial. Then these arteries will distribute that oxygenated blood to every organ in your body. Input is venous, output is arterial. Let's forget the distinction between the right heart and the left heart for a second, and let's just imagine it's one chamber. There is input coming to that chamber, and there is output leaving the chamber. The output leaving the chamber is going to arteries, and therefore is going to be responsible for arterial blood pressure. How do I measure the output of that factory? You need the number of employees working in that factory times the productivity per employee. How many times the heart is pumping per minute is called the heart rate, beats per minute, times the volume ejected per beat. How fast times how strong the heart is beating equals the output of the heart in every minute. Heart rate is measured in beats per minute. Stroke volume is measured in ml or volume per beat. And then the beat will cancel with the beat. And you end up with ml on top, minute at the bottom. This is the measuring unit for the cardiac output, which is about 5 liters per minute or 5,000 mLs per minute. So hey medicosis, how much does my left ventricle pump per minute? 5 liters per minute. How about my right ventricle then? Also 5 liters per minute. And what's the average volume of the adult blood? It's about 5 liters. So you're trying to say that my blood circulates throughout the entire body once every minute? That's true. And your heart has been doing this every minute, in every hour, in every day, in every week, in every month, in every year that you've been alive. Look, these numbers are just approximations to make the calculation easy. So that 100 times 50 equals 1000 mLs per minute. In real life, if you want to be more accurate, this is more like 70 and this is more akin to 70. A pearl for the pros. Do you know the equation of the cardiac output is exactly the same as the equation of what? Minute ventilation for the lungs, which is the ventilation of my lungs per minute. How much is that? Well, how fast is the lung breathing? It's called the respiratory rate. Times how much air do I get in per breath? And this is called the tidal volume. When you multiply the tidal volume times respiratory rate, you get the minute ventilation, which is equivalent to the cardiac output. It's the same exact concept. How fast times how strong. Medicine makes so much sense once you understand what the flip you're talking about. Why should I care about this? Because during pregnancy, the volume of plasma goes up, which means the volume of blood goes up, which means there is more input of blood coming to mommy's heart, which means the output has to be higher. When the venous return that's returning to the heart goes up, the stroke volume goes up, which means the cardiac output goes up. Moreover, in pregnancy, the heart rate also usually goes up. So in a nutshell, pregnancy has high cardiac output, which makes sense because mommy now has to support herself and the baby. Now, is it fair to compare the cardiac output of a tiny person like medicosis with someone huge like Michael Jordan, LeBron James, The Rock, or whomever? No, it's not fair. If you compare my heart to his heart, you will be under the impression that I have heart failure because my heart sucks compared to his. So what should we do? Well, let's make it fair. Let's divide the cardiac output per body surface area. You divide my cardiac output by my body surface area and his big cardiac output over his big body surface area. And when you do this, you will realize that my heart is normal and I do not have heart failure. And this is called the cardiac index. ml per minute is for cardiac output. Square meters is the measuring unit for the surface area. Therefore, here is the measuring unit of the cardiac index. This cardiac output is important because who's going to depend on the cardiac output? Your blood pressure. I mean the mean, average, systemic, not pulmonic, arterial in the systemic arteries like the radial artery, blood pressure, pressure of blood in these systemic arteries averaged. And this equals cardiac output, which equals what? Heart rate times stroke volume multiplied by the total peripheral resistance, which depends on the radius. To keep it nice and easy, think of the resistance as the opposite of radius. But it's not any radius, it's radius raised to the fourth power. The lower the radius, the greater the resistance. If the radius decreased to half of its original value, do you know what's going to happen to the resistance? Please do not say it's going to double. It's 2 power 4, i.e. the resistance will increase and go up. It will become 16 times greater than the original value. So vasoconstriction decreases the radius, increases the resistance, which increases the total peripheral resistance, which means the blood pressure will go up. Conversely, vasodilation increases the radius, lowers the resistance, and lowers my blood pressure. The input is venous, the output is arterial. The cardiac output affects my arterial blood pressure because blood pressure equals cardiac output times TPR. The input is venous, right? So we can call that input venous return. And when the heart is receiving blood, the heart will relax diastole. So the volume of blood in the heart at the end of diastole is the end-diastolic volume, which equals the venous return, which equals the preload, which is the load given to the heart before the heart contracts. Then what would you call the load put upon the heart after it contracts? Afterload, and it will be arterial. Afterload is arterial. Next, many students struggle with the concepts of ejection fraction, end-diastolic, end-systolic, and all of this nonsense. It's a piece of cake. Look, imagine that I gave you 10 apples. You decided to keep 4 apples for you and eject or give away 6 apples. Let me ask you a question. How many apples did you eject? Answer, 6. What's the volume of apples that you ejected? 6 apples. The volume that you ejected is your stroke volume. So the stroke volume is 6 apples. The 4 apples that you decided to keep is the end-systolic volume, which is the volume remaining in the heart at the end of systole, i.e. it didn't leave the heart during contraction. So when I came at the end of systole, after the heart has finished contraction, I found 4 apples still with you that you did not eject. And what do you call the 10 original apples that I gave you? End-diastolic volume. Because at the end of diastole, you just relaxed and accepted all the apples, you had 10. 10 is the end-diastolic volume, 4 is the end-systolic volume. The difference between them is the stroke volume. So stroke volume equals end-diastolic volume minus end-systolic volume. Okay, if I gave you 10 apples and you ejected 6, what's the percentage that you ejected? Of course, it's going to be 60%. That's right, and we call this the ejection fraction. But hey, medicosis, let me ask you a question. Did I eject 6 apples or did I eject 60%? Well, if you're talking in absolute terms, the answer is 6 apples. But if you're talking in relative terms, it is 60%. The stroke volume is 6 because the stroke volume is the difference between the two. The ejection fraction is this stroke volume that you ejected over what I gave you in the beginning. So it's the stroke volume over the end-diastolic volume. And since we know that the stroke volume is EDV minus ESV, we can also say that the ejection fraction is EDV minus ESV, which is the stroke volume, over EDV. What you ejected over what I gave you in the beginning. Absolute terms versus relative terms. So if the heart receives more input, i.e. more preload, which means more venous return, which means more end-diastolic volume, of course the stroke volume will increase. If I gave you 20 apples instead of 10, of course you can eject more. Assuming that you will still eject 60%, 60% times 20 is greater than 60% times 10, which means that your cardiac output goes up because cardiac output equals stroke volume times heart rate. So if the stroke volume goes up, cardiac output goes up. And when cardiac output goes up, arterial blood pressure goes up. What are the factors that affect my cardiac output then? Well, preload affects the cardiac output. Afterload affects the cardiac output. Inotropy, or the force of contraction of the heart, affects the cardiac output, as well as the heart rate. Let's talk about that. Remember, please, that preload is venous, but the afterload is arterial. Hey, preload, I mean venous return, I mean end-diastolic volume, I mean the input to the heart. If you go up, of course, more input equals more output. Let's dig deeper. More input equals more stroke volume equals more cardiac output. What are the factors that will increase the input, i.e. the preload, i.e. the venous return, i.e. the EDV of the heart? How about if I have more blood, like in pregnancy? Or if the doctor gave me too much fluids? This will raise the preload, which will increase the cardiac output. How about increasing my venous tone? Oh, if your veins constrict, they will be able to force more blood from your ankles to your heart upwards. They are squeezing themselves more. More input equals more output. What if I increase the skeletal muscle pumping action? Let's talk about the skeletal muscles of your leg. The reason your blood is capable of going up against gravity is, number 1, that the veins have valves. Number 2 is that your skeletal muscles in your legs contract and force the blood to go up and not down. Third, you have negative intrathoracic pressure in your pleural cavity. The more negative this pressure becometh up here, the more you suck blood upwards, which means the greater the venous return, which means higher preload and higher cardiac output. How about if this atrium contracted more? Then you will push more blood to the ventricle, which means you're increasing the ventricular end-diastolic volume, which means you're increasing the stroke volume, which means you will increase the cardiac output. Let's talk about the opposite, the factors that can decrease the venous return or decrease the EDV. What if I have pericardial effusion? Or worse, cardiac tamponade, accumulation of fluid or blood around the heart. Or what if my pericardium is calcified as hard as a rock, constrictive pericarditis? Do you think my heart will be able to relax and accept all of that blood input? No, my heart will not be able to accept all of that blood. Therefore, what's going to happen? Preload will go down, cardiac output will go down. Similarly, if my ventricle, not the pericardium per se, but the ventricle itself is very stiff, as in restrictive cardiomyopathy, which could be caused by sarcoid amyloid hemochromatosis, cancer, and fibrosis. Do you think my heart will be able to relax and receive all of that input? No. No input equals less cardiac output. Next, how does the afterload, which is arterial, affect my cardiac output? Think about it. Increased afterload could happen because my arteries are constricting. When you constrict something, you increase the resistance, which increases the pressure in the arteries. Now, put yourself in the shoes of the left ventricle. Is it easier or harder for you to pump blood when the arteries in front of you are constricted? Of course, it will get harder. Therefore, what's going to happen to the volume that you will eject? It will get lower, which means the cardiac output will go down. And when you pump less blood, and I look inside that ventricle after systole, at the end of systole, what will be the volume? Oh, more blood will stay here because less blood was ejected. Instead of ejecting 6 apples, I ejected 3. What's going to happen? Well, 7 will remain inside instead of 4, which means the ESV went up. And when the ESV goes up, what's going to happen to the stroke volume, which is the difference between EDV and ESV? Of course, it will decrease. Next, the effect of force of contraction, contractility, inotropy, on the cardiac output. Of course, the stronger I contract, the greater the output. Because if you contract harder, you will eject 7 apples instead of 6. 70% instead of 60%, leaving less apples left after the contraction, i.e. lower ESV, which means the stroke volume is higher because you ejected 7 apples, ejection fraction is higher, cardiac output is higher. Next, heart rate. Be very careful here. Under physiological conditions, if your heart rate increases a little, your cardiac output increases a little. However, don't forget that your body has some regulatory and compensatory mechanisms, which means your body can adjust the venous return, so at the end of the day, no significant change to the cardiac output will happen. However, if your heart rate increases a lot, and I mean crazy fast, and instead of 90 beats per minute, your heart is beating 220 beats per minute. This craziness will give us less time to fill the heart with blood, i.e. less input, which means less output. Even though the heart rate goes up like this and heart rate times stroke volume is cardiac output? Yeah, because when you do this, there is no time for you to fill. It takes time to fill the heart with blood. This crazy fast heart rate gives us less time available to fill the heart, so the cardiac output decreases. And of course, it makes sense that if I'm sleeping, low heart rate, low stroke volume, low cardiac output. Quiz time! A woman became pregnant. Before pregnancy, she was here. Here is my right atrial pressure, and here is my venous return. What do you think is going to happen when she becometh pregnant? So let's talk about that. Here is the baseline. The original point is here. If I go to point 1, it means that the right atrial pressure goes down, but there is no change in the venous return on the y-axis. How about point 2? It means that the right atrial pressure went up and there is no change in the venous return. Point 3 is decrease in both right atrial pressure and venous return. Point 4 is increase in both because the x-axis and the y-axis are increasing. As for point 5, it's only an increase in the venous return when no change is happening in the right atrial pressure. So what do you think actually happens during pregnancy? There is increased plasma volume. And when the plasma volume goes up, what's going to happen? I'll have increased venous return. And when the venous is returning more blood to the right atrium, what's going to happen to my right atrial pressure? It will also go up. So the answer is 4. I've told you before that pregnancy is a cause of hyperdynamic circulation, i.e. high output cardiac failure. We will not call it cardiac failure in pregnancy because pregnancy is not a pathology, it's normal. So we just call it high output state or hyperdynamic circulation, where everything is fast, everything is dilated, everything is distended. Input is venous, output is arterial. Preload is venous, afterload is arterial. Next, let's review what we have talked about before in my video on isometric versus isotonic contraction. You will find it in my muscle physiology playlist. Suppose that I'm trying to pull this, but I cannot pull it. It's so heavy I couldn't pull it. Do you think my muscles are shortening? No, I could not. I wish I could shorten my muscle, contract it, and pull it here. I could not, which means the length of my muscle stayed the same. Iso means the same or equal. Metric means the length from meter. The length of the muscle did not change, i.e. isometric contraction. You know what did change? The tension went up. So in isotonic contraction, isotonic, the tone stays the same. What changes then? The length of the muscle changes. It got shorter because I was capable of pulling up the weight. In isometric contraction, however, iso, same length, there's no change in the length. What happened? The tension went up. In isotonic, the tone is iso, did not change. What changes is the muscle got shorter. So look at this. Yeah, the muscle got shorter, i.e. there is an actual change on the y-axis. But in isometric contraction, the length of the muscle stayed the same. What increased then? It's the tone. It went up, as you see here. Quiz time. Which situation among these three will help you throw your arrow farther? Please pause. What do you think? The answer is B, of course. With optimal stretch, you get the best response. Just like your heart, if the preload increases a little, optimal increase, the heart can accommodate this. The heart will relax more and pushes more. But if the preload increases too much, what do you think is going to happen? Lower stroke volume and lower cardiac output. The best point, the highest point, the maximum contraction happens with optimum stretch. Less than that and you get less contraction. More than that and you also get less stroke volume. And this is called what? The Starling Law. The greater the initial muscle fiber length, i.e. preload, the more will be the active tension developed during its isometric contraction. Ad infinitum? No, within limits. If you go too far, you will get the opposite result. Quiz time. Which situation among the three will help you throw your arrow farther? Please pause. And the answer is B again. Why? Look at A. There is overlap between the myosin and actin. They are just on top of each other. That's not good. Stretch me more, please. Oh, look at this. That's optimum. So that we have the greatest number of cross bridges between actin and myosin. But if you stretch me too far, look at that. Myosin can barely grab the actin. Same idea again. Which situation is the most optimum? The answer is B is the most optimal, of course. He who better understandeth muscle physiology wins in the Olympics. So increase the preload might be okay for the cardiac output within limits. Here is my stroke volume against the end-diastolic volume, and here is my baseline. Between graph A and graph B, which one represents the effect of dobutamine on a healthy heart? Please pause. Let's talk about that. What does dobutamine do? Dobutamine is a beta-1 agonist. When you stimulate beta-1 on the heart, what do you get? You increase heart rate. You also increase the force of contraction, which increases stroke volume, both of which will increase my cardiac output. So the answer is A. In either case, here let's take the same point from the x-axis because I'm giving you 10 apples each time. In the first situation, you only throw back 3 apples. Here, 6 apples. Here, 8 apples. So of course 8 apples is the highest stroke volume and the highest cardiac output. This is a positive inotropic drug. Here is my cardiac muscle cell. Here is my beta-1 receptor. And here is dobutamine stimulating the beta-1 receptor. Beta-1 is GS coupled, which means I'll activate adenylate cyclase. which means we'll convert ATP into cyclic AMP, which activateth protein kinase A, which opens the calcium channel. Calcium enters into the cardiac muscle cell. Calcium induced calcium release. From where? From the jail of calcium, the sarcoplasmic reticulum. And this calcium will make actin and myosin bind to one another, and boom, you have contraction. Of course, it's good to have normal preload and afterload. If I've told you that you have been cursed by one of these, either high preload or high afterload, which one will you choose? I'll choose high preload, because within limits, I can counteract this. I can adapt to this by increasing my force of contraction. However, when you increase afterload, well, it's called afterload for a reason. After the heart contracts, the heart was surprised that there is too much load, too much resistance in front of it due to vasoconstriction, atherosclerosis, hypertension, etc. So the afterload is evil. Preload is venous, afterload is arterial. An increase in the preload is less evil than the increase in afterload. When it comes to the afterload, the greater the load that you add on top of the heart, what's going to happen to the velocity of shortening, i.e. the contraction, shortening of muscles, it goes down. It's an inverse relationship. Translation: the greater the afterload, the lower the stroke volume, and vice versa. Afterload is evil. Quiz time. Weightlifting. We have two types. There is the snatch and there is the clean and jerk. Which one do you think is easier? Please pause. The answer is the clean and jerk. Why? Because I can hold this bar up here for a while and anticipate and feel its weight so that the next part is expected and therefore easier. But here, I have to snatch it very quickly. This is like increased preload. You can expect that and adapt to it. And this is the increased afterload. If you do not believe me, go look at the Olympics records for the same player. You'll find that for every player, their record on the clean and jerk is higher than the record on the snatch. It's all about physiology, baby. It's all about Starling Law, which is not to be confused with Starling forces, i.e. hydrostatic pressure versus oncotic pressure. Hydrostatic pushes, oncotic pulls. Hydrostatic pressure, which pushes, depends on the volume of the plasma. Oncotic pressure depends on the proteins in the plasma, namely albumin, because it's more numerous, because osmosis cares about the number of particles and not the size. Osmosis is a colligative property. And remember when we talked about this in your kidney? Here's the afferent arteriole, and here is the nephron. If I'm pushing, I'm hydrostatic. If I'm pulling, I'm oncotic. This is true for the afferent arteriole. It's also true for the nephron tubules. If I'm pushing, hydrostatic. If I'm pulling, oncotic. Each one of these four forces can be measured in millimeters of mercury. And then you give me the net filtering pressure. Net filtering pressure if I'm trying to move from here to here. Look at this arrow, which is capillary hydrostatic pressure. Are you with me or against me? With me. So it's a positive number. How about you? With me. It's 0. It's also positive here. So 60 plus 0, that's on one side. Who are the forces that are against me? You are against me because I'm trying to go this way and you're moving in the opposite direction. And you are against me. Add them together and get the difference. 60 on one side, favoring forces, minus 50 on the other side, opposing forces. The end result is a positive 10. If it's positive, we're going this way. If the net is negative 10, we're going the opposite way. So please do not confuse Starling forces with Starling Law. If you want more detail about Starling forces, check out my video titled Starling Forces in my cardiology playlist. Next, let's talk about compliance. Compliance is the same as, or almost the same as, expansibility or distensibility, the ability to expand, i.e., increase your volume given a certain pressure. Large veins can expand, expansibility, compliance, distensibility, big time. Therefore, their compliance is high relative to arteries. When I constrict my vessel, you're constricting, you're pushing in, it gets harder to expand. So compliance goes down. As I get older, or as I develop worse atherosclerosis, my arteries get more stiff, i.e., harder to expand. So compliance drops. What's the difference between static versus dynamic compliance? Just ask yourself, is the factor changing from day to day, or does it take way longer than that? If if it's changing on day to day, this is dynamic. Such as the degree of sympathetic activity. Yeah, today in the morning I can have a certain sympathetic activity, and then in the next minute it changes, goes up or down, so that's dynamic. But age, atherosclerosis, well, these take a long time to change, and this is called static compliance, which means that atherosclerosis and old age are decreasing which kind of compliance? The static one. But when the sympathetic constricts vessels, that's the dynamic one. Compliance is the opposite of stiffness. If my arteries become more stiff, they become less compliant. Moreover, compliance is the opposite of elasticity. If something is more compliant, it is less elastic, and vice versa. Do you remember my lung with emphysema? It was like a lax rubber band sock. Very old sock. Easy to expand. Yeah, but then when you let it go, it will never recoil back because the rubber band is toast. Is this compliant? Yeah, because compliance means expansibility. It's very easy to expand, so it's very compliant. Is it elastic? Oh, heck no, because it cannot recoil on its own. The exact opposite is the lung with pulmonary fibrosis or restrictive lung disease. The rubber band is very strong and the sock shrinks even more in the laundry washing machine. Is it easy to expand? Oh no! So compliance is low. Is it easy to recoil? Yeah, it's very good at recoiling because the rubber band is very strong. So elasticity is high. Quiz time! Which of the following graphs represent superior vena cava? Is it X or Y? How about which graph represents a branch of the radial artery? X or Y? Which one is more elastic, X or Y? Answer. The superior vena cava is a big vein. Veins are very compliant because you can expand them big time. A branch of a radial artery will be an artery or an arteriole. Arterioles are elastic, but not compliant relative to vein. So the answer is Y. It's easier to expand a vein than an artery at a given pressure. So which one is more elastic? The one that's more elastic is the one that is less compliant, i.e. the artery. So relatively speaking, veins are more compliant, arteries are more elastic. This is a nugget. Next, let's talk about the cardiac cycle and the topic that everyone loves: pressure-volume loops. Please watch the video in my biology playlist before this one. Left ventricle, aorta, the rest of the body, and then superior inferior vena cava, go right atrium, right ventricle, pulmonary arteries, lungs, and back to the pulmonary veins. When valves close, they give us a sound. When they open, they give no sound. The first hard sound is caused by closure of the mitral and tricuspid valve, but the second hard sound is due to the closure of the aortic and the pulmonic valves. Which one happens first, electricity or muscle contraction? Electricity first. Which means the P wave happens first, then the atrium contracts. The QRS wave, electricity, happens first, then the ventricle contracts. The T wave happens first, then the ventricle relaxes. Who contracts? Well, the atrium can contract and the ventricle can contract. But when we say systole in general, most of the time we're referring to the ventricle. If I want to refer to atrium, I will say atrial systole. But if I just say systole, I mean ventricular. Same thing with diastole. Normal blood pressure, 120/80. Where is that pressure? It's in the big arteries. This is not the pressure in your heart chambers. What's the pressure in my heart chambers then? Let me start with the first number, which is systolic. In your left ventricle, well, where do you think you got the 120 systolic from? You got it from your left ventricle. So it's 120 during systole. How about my left atrium? 10 during systole. How about my right atrium? 5. Right ventricle, 25. Mnemonic, just remember Uncle Sam and his coins. 5 cents, then 10 cents, and then 25 cents, and then I give you $1. Nickel, dime, quarter, dollar. These numbers that I just gave you are the systolic numbers. If you want the diastolic, all of them are almost zero. You can say 3, 4, 5 millimeters of mercury. No one cares. But be careful of the right atrium, because since it has to suck in blood through venous return, sometimes it becometh negative, which helps suck blood from your ankles up to your heart through venous return. Where did it get the negative from? Don't forget that your intrathoracic or intrapleural pressure is already negative. So the next organ, which is the lung, has negative pressure, so this organ will acquire similar pressure. Moreover, if you expand, your volume will go up, but your pressure will go down according to Boyle's law, provided that the temperature stays the same, and as you know, the body temperature stays the same around 37 degrees Celsius. So what's the normal blood pressure in big arteries? 120 during systole, 80 during diastole. What's the pressure in my left ventricle? 120, same, during systole. Almost zero during diastole. So if I ask the aorta, hey aorta, where did you get the 120 from? I got it from the left ventricle, which makes sense because the left ventricle contracts and pushes the blood here. But hey aorta, where did you get the 80 from? Please don't tell me that you got it from the left ventricle because the left ventricle doesn't have an 80 to give. It has zero during diastole. No, that's something unique to me. I am capable of recoiling around that blood. As I recoil, what's going to happen to the volume? Decreases. What's going to happen to the pressure? Increases. Instead of 0 during diastole, it increases to 80 because of the elastic recoil, something that's unique to arteries, not to ventricles. And this is the cause of the dicrotic notch or the dicrotic incisura of the aorta that you see, cardiac cycle graphs. Next, what do you think happens to the left ventricular volume as it pushes blood out of it? Of course, the volume goes down. But when it's receiving blood into it, the volume goes up. And therefore, we can put everything that we know so far on one graph. This is the pressure graph. The pressure of the ventricle goes to 120 upstairs and almost 0 downstairs. Systole versus diastole. But if you're talking about big arteries like the aorta, radial artery, brachial artery, etc., they go to 120 during systole and 80 instead of 0 during diastole, thanks to their elastic recoil. Remember, arteries are more elastic, veins are more compliant, relatively speaking. And here is the volume decreasing during systole, increasing during diastole. It's the volume of the ventricle. S1, closure of the mitral and tricuspid valves. When do they close? Just before systole, just before blood leaves the ventricle and goes to the outside. These two valves close to prevent the backflow of blood from the ventricle to the atrium. How about S2? Closure of the aortic and pulmonic valves. When does that happen? Just before diastole, just before my ventricle fills with blood, to prevent the backflow of blood back to the ventricle. And here's the EKG. Remember, electrical changes first, then muscle contraction. Electrical changes first, then the ventricle contracts. S1 is here, S2 is here. Where should I put the pathological S3 and S4? Well, S3 is caused by the gush of fluid, volume overload. Blood starts to gush here in diastole because the ventricle is receiving a gush of blood, so S3 is here. How about S4? Just before the following S1 heart sound. Here is systole, the ventricle is contracting, and here's diastole, the ventricle is relaxing and receiving blood. In contraction, in the beginning, the ventricle is contracting, but the aortic valve is not opening yet, which means the ventricle acts as a closed chamber. Closed on this side because the mitral valve is closed, and closed on this side because the aortic valve is closed and has not opened yet. So it's called isovolumetric. The volume of the ventricle is the same. It could not shorten and shrink. After this, the saving grace, the aortic valve will open. Phew! All of that blood will leave the ventricle and go to the aorta. Rapid ejection. Everything that goes up must eventually come down. Reduce ejection. I'm still ejecting blood at a lower rate. Conversely, in diastole, in the beginning, everything is closed. The heart acts as a closed chamber. So it's isovolumetric relaxation. After this, the mitral and tricuspid valves will open. So the blood will gush from atria to ventricles. Rapid filling followed by slow or reduced filling. This leaves a few drops of blood in the atria, so the atria will contract, atrial systole, to push those few bloods down to the ventricle. Now onto the pressure volume loop. Why do you call it pressure volume loop? Because pressure is here, volume is here. It's easier to look at the volume first. As the volume increases from here to here, do you think this is systole or diastole? If the volume of the ventricle increases, of course this is diastole. Conversely, if the volume is decreasing from this point to this point, what do you think is happening? It means that the blood is leaving the heart, leaving less volume inside the heart. So I'm decreasing. Diastole is here, systole is here. How do you get the blood to be ejected? I have to contract first to push that blood. In the beginning, the heart was a closed chamber, isovolumetric contraction. After this, the aortic valve opened and phew, I ejected that blood. Rapid filling, reduced filling. How do you get the blood to come to you? I have to relax first. In the beginning, it was isovolumetric. What do you mean by isovolumetric? I mean the volume did not change. From this point to this point, I'm still on the same point on the x-axis. Isovolumetric relaxation. After this, the mitral and tricuspid valves will open and the blood will gush into the ventricle and the volume will rise. Oh, by the way, the same graph can be used for the right ventricle, pressure versus volume. How do I know that this is talking about the right ventricle? Look at this number. It's 30. Oh, it's not 120. Yeah, this belongs to the right ventricle. Or you can do the same thing for the left ventricle. How do I know it's the left ventricle? It's 120 millimeters of mercury. That's the stronger, thicker ventricle. Or you can plot the left ventricle against the right ventricle. I think you can see the difference between the 120 and the 25. This is the pressure during systole in the left ventricle, and this is the pressure during systole in the right ventricle. During diastole, however, both of them are almost zero, unlike the big arteries that are capable of elastic recoil. Let's take it to the next level. We agreed that diastole is here because the volume goes up, and that systole is here because the volume goes down. Before we can get systole to happen, the heart acted like a closed chamber, isovolumetric ventricular contraction. Before the ventricle was able to receive the blood during diastole, it acted as a closed chamber, isovolumetric relaxation. When did the saving grace happen? When the aortic valve opened, allowing the blood to be ejected and the volume to decrease. And then what? After the blood gets ejected, rapid ejection and then slow ejection, the aortic valve will close to prevent the backflow of blood to the left ventricle. And when the aortic valve closes, it gives you a sound. It's S2 sound. After this, the ventricle will start to relax, but still the mitral valve is closed, so the ventricle acts as a closed chamber, isovolumetric relaxation, until the mitral valve opens and blood flows from left atrium to left ventricle. Blood is flowing right here and I'm filling. After this, the mitral valve will close so that when the ventricle contracts, blood does not flow back from the left ventricle to the left atrium. And when a valve closes, it gives you a sound. Mitral valve closure gives us S1. What's the highest volume ever in your left ventricle? It's the end-diastolic volume. And what's the lowest volume? It's the end-systolic volume. And what's the difference between them? It's called the stroke volume. Example, if my end-systolic volume is 120 ml and the end-systolic volume is 40 ml, can you calculate the stroke volume, please? It's 80 ml. 120 minus 40 equals 80. So the distance between this point and this point is literally the stroke volume. 120 over 80 is the pressure not in the ventricle but in big arteries. This is called systolic blood pressure and this is called diastolic blood pressure. The 120 is the same point as the greatest pressure ever in the left ventricle. It's called the maximal afterload pressure or the systolic pressure in the left ventricle. How about the diastolic pressure in the left ventricle? Almost zero. You can call it the left ventricular end-diastolic pressure, while the left ventricular end-systolic pressure is here, not quite 120. Why not? 120 was the maximal point in the midst of systole. But if you want the end systolic pressure, it's gotta be a little less, usually between 120 and 80. If you are a math nut, you remember that under every curve, there is something called area under the curve that can be calculated through calculus. Since this is not a curve, this is a loop, we have area inside the loop. It's called the stroke work, i.e. the energy required to eject blood in a stroke. Hence, stroke volume. Hence, stroke pressure. Quiz time. From this graph, can you calculate the stroke volume, the ejection fraction, and the systolic blood pressure, I mean in a big artery? And can you tell me which of these points, A, B, C, D, E, F, G, etc., represents S3, heart sound, and S4? Please pause. Let's answer these together. Stroke volume is what? End-diastolic volume minus end-systolic volume. Here's the end-diastolic, here's the end-systolic. So it's 120 minus 35 equals 85. 85 what? Milliliters. Next, ejection fraction. Ejection fraction is what? Stroke volume, I just got that, over end-diastolic volume. My stroke volume is 85. my end-diastolic volume is 120, which gives me something akin to 71%. That is some robust ejection fraction, I can tell you that. Systolic blood pressure, i.e. blood pressure in big arteries during systole, the highest number of course, which is 120 millimeters of mercury. The point at which S3 is heard. S3 is abnormal. It's caused by gush of fluid. The fluid is gushing the most at E. Look at this. It's called rapid filling, baby. So it's E. How about S4? S4 happens just before S1. And where is S1? S1 is B. The point just before it is F, as in F me. Quiz time. You have 3 graphs here. Which one represents a healthy heart receiving digoxin medication? Please pause. Let's try to answer this together. Let me tell you something. You know what the slope of this graph is? You find yourself the point of origin, which is the 0 point here, and you go up, 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 up until you intersect with this point right here. Now you have a straight line that you can calculate its slope. If you remember from basic math, slope equals what? Rise over run. It also equals tan of this angle, which is the angle between that line and the x-axis. Not the y, not this angle. Nope, nope, nope. You'll mess it up. This angle right here. Okay, so that's the slope then. It's how big the angle is. Perfect. Let's compare among these 3. Here is the slope for graph B. It's a smaller angle. And here is the slope for graph C. Even smaller angle. The slope represents contractility, the force of contraction. Digoxin increases the force of contractility, which means you should choose the graph with the highest slope, highest force of contraction, which is A. So let's dot the I's and cross the T's. S3 is here, S4 is here, S1 is here, S2 is here. What's the slope of this line? It represents contractility. If you go this way, the angle gets bigger and contractility increases. If the entire graph is shifted to the right, then the angle decreases and contractility goes down. This was the best explanation of pressure volume loops ever. Systole, diastole, S1, S2. Pause and review. If you want to be an excellent student, bring a piece of paper and draw everything on the pressure volume loop from scratch and explain it to yourself as you go. Do it 3 times today, 3 times tomorrow, and 3 times next week, and you will remember this for a long time. This graph is important in physiology, it's important in pharmacology, of great importance in internal medicine and surgery. Don't forget to say thank you to Jordan in the comment section. If you want to learn more about many arrhythmias, heart attacks, and strokes, download my emergency medicine high yields course at medicosisperfectionalis.com. If you want to learn about the normal changes during pregnancy and the abnormal diseases that happen during pregnancy, such as gestational diabetes, preeclampsia, eclampsia, acute fatty liver of pregnancy, peripartum cardiomyopathy, and much more, download my OBGYN high yields course. And if you want to learn about anti-arrhythmics, anti-anginal, anti-hypertensive medications, and even anti-hyperlipidemics, download my cardiac pharmacology course. If you do not wish to download my courses and you would rather watch them on YouTube, you can do so by clicking on the join button and choosing the highest tier. It will open up more than 300 premium videos for you that you can watch right now at double the playback speed if you want. Education is fun. Please subscribe, hit the bell, click on the join button. You can support me here or here. Go to my website to download my courses, notes, and cases. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense. Thank you, Jordan.